Hello all, once again continuing with the examination of the WPATH files, in this case examining them in light of some historic information from GenSpect. GenSpect is an organisation that offers support and guidance to parents with who find themselves caught in this, and also to detransitioners, and have done immense work in this field in many areas. What I'm going to talk about today is essentially a guy called Dr. David Bell, who some of you may or may not be familiar with. And I have a video first that I think you should watch before I dig in to Dr. Bell's latest article, which I think will give you a flavour of the thoughtfulness, the care, and the intelligence of this deeply brave man who took this on long before many people in his profession did. Please now watch Dr. David Bell, courtesy of GenSpect's conference.
As a medical student, I attended a lecture by Hans Eysenck on his electric shock treatment to decondition gay men. In the discussion, a young gay philosopher, as I later learned when I spoke to him, asked if there were not any ethical matters that needed consideration. Eysenck responded that these men were suffering as a result of being homosexual and sought help. We have, he said, the technology to relieve them. There needs to be no further ethical consideration. The questioner suggested a thought experiment. He said, let us just imagine for a moment, Professor Eysenck, that you are an orthopedic surgeon, and that one day a man approaches you complaining, I cannot bear my arm. It is ugly. I never know what to do with it. My wife also hates it. I don't know where to put it in bed. Look, it's covered in bruises. I'm always knocking it. Would you just please remove my arm? Well, said the questioner, I think you might, Professor Eysenck, send him to a psychiatrist to find out what is, and say to him there's something wrong in the relation between the man and his arm. You would not, I think, say we have the technology to relieve him of his suffering and so proceed to amputation. There was a deafening silence in the room. The point here is, of course, is the homosexual man who seeks treatment of this type is not sovereign over decisions as to what afflicts him. For there would be individual, family, and social determinations, including for that, such a man living in a world where hatred of homosexuality would be a daily experience, things that would affect him beyond awareness. However, the last time I told that story, I was disturbed to learn that in the USA, there are surgeons who will amputate under these conditions. Here, patienthood has collapsed completely into customership, and so wish transcends any conception of need, and externality is annihilated. It is indeed strange to be living in a world where, when I was working at the Tavistock, I received a referral from a plastic surgeon of a man who asked for surgery on his nose. The surgeon had met this man a number of times and decided there was nothing wrong with his nose, but there was something wrong with his relationship with his nose. After a year's psychotherapy, the man discovered, or didn't discover, but more recognized the centrality of the hatred of his father in his life, particularly in relation to some very early traumatic experiences, and understood that his nose was like his father's. He gave up his wish for plastic surgery. Meanwhile, a person with acute gender dysphoria, with only a few consultations, may well find agreement to change her name, commence medication, and be heading for surgical removal of her breasts and genitals. Any questioning foreclosed. It needs to be emphasized here that when someone starts on puberty blockers, for which, as I said, there is no evidence of, we do not know what the effects are. There's certainly very strong evidence of effects on bone, effects on cognitive development, effects on brain development. But also originally when they were being used in this context, there was an idea of an interregnum, that they would delay puberty. But here, even that is not the case, because 98% go on to opposite sex hormones. This means that starting a patient on puberty blockers has all the weight on it in terms of consent of starting them on a pathway which may well be irreversible. Many years ago, when I was young, So not many of you will know this, but if your television didn't work, you might get some wavy lines on it. And you would twiddle one of the knobs to sort of change it so that the lines disappeared. But sometimes you get a message from the broadcaster. Do not adjust your set. There's a problem with the signal. A version of this made its way into a popular political slogan. Do not adjust your set. Reality is disturbed. However, the current predicament is so much darker, as Jude, in fact, has particularly showed us. Serious questions have been raised concerning the ethics and safety of these so-called medical and surgical treatments, which are offering surgical and medical solutions to psychological problems. It is to be hoped that this discussion is part of a critical engagement. There's now a much broader debate in the media and than would have been possible only a few years ago. So maybe the pendulum may be swinging a bit the other way. But there are many beleaguered colleagues who are struggling to maintain thought and ethical responsibility, and they need our support.
Interesting. A deeply thoughtful and intelligent man talking about his historic understanding of where we are and bringing in other factors to explain some of why we see what is going on is happening, for example, in terms of amputees, those that wish to amputate their body parts, and also those who have relationships with their body that are based on something externally from the body. Fascinating stuff, I'm sure you'll agree. So I was very pleased to see in Artillery Row over at The Critic that Dr. David Bellis provided us with an article in reference to WPATH. We're joining the dots here, people, and I hope you're following along with me. We're joining the dots. Down the primrose WPATH. Responsible medical authorities must reflect the dangerous nonsense of gender-affirming care. Many critics of gender medicine, myself among them, have long been aware that treatments are being given to children and adolescents for which there is no evidence of benefit and growing evidence of serious harm, both physical and psychological. These include social transition in early youth, puberty blocking in early puberty, and cross-sex hormones from age 16. David couldn't be any clearer there with what he's stating and saying. This absolutely is what is going on. Thus, we have regarded these treatments in children and young people as experimental, with none of the caution and safeguards required for responsible evidence-based medicine. And there's the key word, safeguard. Safeguard. And he then continues, evidence-based medicine for all ages, but most especially when it comes to minors. You know that this isn't David, this is me. You know what I'm like, the whole thing stops. The whole thing stops. There should be no such thing as gender and trans medical care. It's just psychological care. It shouldn't even be branded as such in my book, but that's just me. We think, David says, it is not possible that these young people are able to give meaningful consent. This is in part because of their youth, which means that they aren't able to grasp the true scale of the many long-term consequences, which may include sterility. Some are in acutely disturbed states of mind and therefore unable to understand the implications of embarking on a medical pathway with major permanent consequences. And finally, informed consent requires research data on outcomes, which does not exist. David highlighting there that this is medical malpractice to me on a grand scale. I think that's what he's saying. I think that's what his words are illuminating for us. You know as well as I do, I've got a friend who is dealing with somebody who has severe anorexia and they've adopted a trans identity. The trans identity is a symptom of their severe anorexia. We must not be confused into thinking that this has any medical basis whatsoever. It doesn't. Gender identity doesn't exist. Gender expression is fashion. This is an illness that needs to be treated as such. Okay, we should never have made an illness into an identity, and let alone a category that needs protection. Because what we've got then is young people who we can't tell the truth to. It's a terrible thing. It's a terrible, terrible thing. Moving on. We have campaigned for years to bring the matter to public attention. David, there are referencing GenSpect. But from the beginning, we have faced opposition from within the NHS, universities, and other public bodies that have been captured by gender identity ideology and abandoned a balanced scientific approach. This has been known for a long time. The WPATH files are the confirmation. They are the red stamp, aren't they, of the reality of what we've all been saying for a very long time. We have seen articles pulled, speakers dropped, and even entire conferences cancelled simply because they are sceptical about overblown, unevidenced claims. Over the past few years, this has started to change, and we are increasingly getting a hearing at conferences and in the media. However, it has remained an uphill struggle. Only a few weeks ago, the Royal College of General Practitioners considered cancelling a meeting of international experts wishing to address the harm being done to gender-distressed young people. I think it's sex distress. I think it's about the body, David. I mean, I'm not where you are, for goodness sake, but I think it's about the body. Central to the penetration of ideology into various institutions, including medical ones, has been the World Professional Association of Transgender Health, or WPATH. This body has been treated both by professional associations of medics and clinicians and by the media as if it consisted of experts with the knowledge and training to be able to opine with authority. But this is simply not the case. Membership of WPATH is not restricted to clinicians. Anyone at all can join on the payment of a modest fee. Its so-called standards of care, in fact, no such thing. Their various chapters of the current version were produced by subgroups containing many people with no medical or therapeutic qualifications, and without reference to standard medical requirements to weigh evidence properly or consider such matters as patients' capacity to consent and harmful side effects of the treatment. WPATH promotes non-binary identities, neither male nor female, and experimental surgeries that gave people the appearance of having both male and female genitals, or neither. There is no evidence base suggesting that such surgeries are medically necessary or advisable, or even that they make people feel any better. It also claims that boys can be born with a eunuch gender identity, and that suitable treatment for such boys might be castration. This shocking statement is similarly unevidenced. There's a lot more to the article that David has taken the time to write, so you should take the time to read, as I normally say. We're connecting the dots, folks. We're seeing how this has all come about and where it's all going. The files themselves will be read by many. I think it will be seen by many, and I think it will be understood by few. But that's just me being a misery guts, right? Other than that, buy me a coffee if you can, keep the work going. I'm inundated. And just, yeah, come be a word teacher. That's the best thing you can do. Come and join the crew and see what we're up to. Glorious. Okay, so thank you very much for watching once again. And I hope you're enjoying this series on, that's not the right word, is it? And I hope that this is proving useful for you, this series on the WPATH files. So go on, buzz off.